First of all, lurbinectedin and irinotecan, these are both standard of care regimens. We use them as individual agents or solo treatment in both of them. So we're using commonly used drugs within the management of small cell lung cancer. So the question is there synergy in giving the two in a combination? There's preclinical work with multiple cell lines to suggest a degree of synergy, but really the most meaningful data is when we get clinical data. There was previously an initial 21 patient cohort where we saw some very promising results. And that's now a larger cohort, which is what was reported out at ASCO this year. And so an exciting look at the data to suggest further synergy, which I know we'll get to. So the enrollment criteria were pretty similar to what we see in a lot of small cell trials. This was a true second line. Patients had to have received one prior line of therapy. They could not have active brain metastases. So any previously seen brain mets would have to be treated, which is typically radiated. Also had to have a performance status of 0 to 1. Now, the majority of patients in the study did have performance status of ECOG 1, which is very common for the patients that we see with small cell lung cancer in this line. So this is very encouraging to see. Now, in standard practice, if we go by NCCN guidelines in the second line setting, particularly in those with progression that is in a less than 6 months from prior chemotherapy. So a chemotherapy-free interval of less than 6 months. I'd say lurbinectedin is very commonly used in that population. Lurbinectedin is also used as a second-line regimen for many when the chemotherapy-free interval is longer than 6 months, but certainly in less than 6 months on NCCN guidelines, it's really very high in the list of second-line regimens. Topotecan is another second-line regimen. That's the other FDA-approved regimen, and irinotecan is the other option. We see that in the NCCN guidelines. In many institutions, they'll use irinotecan rather than topotecan. So really kind of putting it into that second line consideration. In the second line setting, so basically we have lurbinectedin or irinotecan, and now we're saying, okay, we're going to take these two and combine them in this synergistic, or at least that's the goal, is a synergistic line of therapy. To see response rates in the 40%, this is numerically certainly better than what we see with single agent in either case. So from a response rate standpoint, I find this particularly encouraging to see response rates in the 40% as opposed to with the lurbinectedin single agent in the 30% that led to the FDA approval and current second line standard of care option. Or what we see in the earlier data, this is from many years ago for irinotecan. So the response rate is very encouraging. Now, the other component of this is the dosing. So lurbinectedin in this study was dosed at 2 milligrams per meter squared, which is lower than the single agent dosing, as well as the irinotecan being dosed at 75 milligrams per meter squared, which is lower than the more standard dosing. So at a lower dose of the two of these, we are seeing what looks like, at least numerically, a response rate that is more than what we see from either of the drugs, further lending to this suggestion of synergy. And then just the context, in the 40%, this is saying from a response rate standpoint, meaning that the percentage of patients where we see at least a 30% reduction in their tumor volume, this is more than 40% of patients, is very encouraging. Of course, we also then have some patients with stable disease that doesn't show up in the response rate, but we do see some durability in stable disease as well, with some of the longer responders having stable disease, which is just to say that those longer stable disease cases are not what's going to show up in the response rate necessarily. So the benefit to the drug goes a bit beyond just that 40%. So adverse events are around what we would expect. With irinotecan, we certainly see diarrhea, and we see that as well in this. With both irinotecan and lurbinectedin, we see cytopenias, and we certainly see cytopenias in this case. I'll point out, single agent lurbinectedin is once every 3 weeks. And so giving some kind of treatment to reduce the time of neutropenia is a bit easier in that scenario. Irinotecan is day 1, day 8. And so the dosing trying to give some kind of prophylaxis is a little bit harder in that case. So we do see cytopenias with this and diarrhea. Those are two of the most common toxicities. Another one to point out is fatigue. Fatigue is something that can happen with either of them. I don't think of fatigue so much with lurbinectedin as a single agent. From the basket trial that led to the FDA approval of single agent lurbinectedin, we saw a 7% grade 3 fatigue. So not very common, but certainly can happen. And the fatigue was more common with this combination. Not at a level that would prevent use, but certainly at a level that would have me discussing that and looking for that maybe a little bit more so, or anticipating it, I should say, a little bit more so than either of them as a single agent. I think those are really the toxicities to highlight. Overall, from this, essentially we see a toxicity profile that we would anticipate given the toxicities of each of these as single agents, and something that I would expect to be manageable, but certainly some toxicities to look for and potentially have to manage. So these results are encouraging. I haven't yet highlighted, but I should, that the median chemotherapy-free interval was less than 90 days. So this is a population of patients where we would not expect to see the best responses. It wasn't the population with the best prognosis, and even in that setting, we see encouraging results. Now, the median chemotherapy interval was approximating 90 days or approximating 3 months, but was a little bit less. So these are encouraging results. Do they immediately change standard practice? Well, we need to see a randomized trial. Thankfully, we have one underway. The Lagoon trial is a combination lurbinectedin plus irinotecan versus lurbinectedin as a single agent versus in the third arm, either topotecan or irinotecan. So in this, I personally have been enrolling in patients that get standard of care. I give them irinotecan per my standard practice, preferring irinotecan rather than topotecan due to toxicity profile. But this 3-arm study is continuing to accrue and will be an opportunity to now look at combination results relative to each of these single agents. So very encouraging single-arm study. We see response rates that are encouraging to see, and now the randomized trial currently underway, and will give us that randomized data that I think is going to be important to know where this may or may not fit in within the current treatment paradigm.